This conference will now be recorded.
All right. Do you want to go first? Or you want me to?
I can.
Okay. I'll give you control here.
Should be able to see it now.
Yep,
You see my database screen?
we do.
Okay. All right. Um, so this is a patient who originally presented like 15 years ago, 14 years ago, with a type A dissection. You can see an entry tear just above the sinuses. And they also had coronary disease. Their left main, they've got some calcium. It's hard to see on this. I don't think that the dissection was actually involving the coronaries, but you can see they've had a looks like a little thinning, some fatty metaplasia, so they've had a prior infarct. So they undergo a at the same time as they do the ascending and hemiarch repair, they do a bypass, and you can see there's a lima. They did one vein graft, which is already out. This is the osteal marker, and you just see a slight little nubbin. And this was a couple of years after the surgery. And then fast forward to this year, and I'll show two radiographs because I think this is where it gets really interesting. They had a pacemaker or AICD placed this year, and that was a few months ago. And then this is the more recent radiograph, and the it is a different technique, but the mediastinum just looks a little fuller, particularly on the right. It might have been a little bit rotated there, but the subtle finding, and this was all at the outside hospital, so I'm showing this in hindsight, knowing what was going on, but I think it's a really interesting finding on the radiograph. You can see the right paratracheal space just looks a little thick. The trachea even looks like it maybe even bowed a little bit to the right here. But notice the osteal marker was right there, and it is now, this is it right here. It's vertical, it's changed its orientation, or it's not, it was vertical before, but it's changed its orientation where it's really, you're seeing it, in profile rather than kind of oblique or en face. And this patient had been having recent worsening, just fever, B symptoms, and had developed chest pain. And so here's the CT, and you'll see what it shows based on that, based on the clue being the migration of that osteal marker, is that there's a huge pseudoaneurysm now. That wasn't here even a year ago, prior to that AICD being placed. And sure enough, there's that osteal marker that's displaced, and you see the blush of contrast right next to that. So this patient has symptoms of bacteremia. Uh, they are unfortunately, due to comorbid conditions, not a surgical candidate. I don't know if they've grown anything yet, but this is all just a huge pseudoaneurysm, presumably from dehiscence or just, loss of that anastomosis of their osteal marker. What do you think, Jeff? Pretty interesting, huh?
Crazy, yeah. They don't use those osteo markers much anymore.
Our surgeons still, some of them do. I don't know. I guess it depends on the approach too. If they're doing more minimally invasive, we often don't see them as much.
Yeah, because
But
now,
I thought
you just use the CT to find the osteum.
right. But yeah, this is it's like a
That's a
sneaky
great,
finding. You could,
great
yeah.
observation. Yeah, I wouldn't even seen the marker on that second one because it just looks like it's a piece of the wire.
Yeah, I know, right? And in pre-CT days, it was stuff like this or change in orientation of a prosthetic valve that clued you into
Hmm.
some sort of surgical failure. I mean, obviously now we have the benefit of this, and so it's more just an academic exercise, but it could save somebody on here in the future when they're looking at one of these prospectively.
That is the only case I've seen where the marker was of any use. David's on now. We'll see if he has
Oh,
any comments.
David's on here now.
Yeah, because he's probably seen a lot more of the markers than we have.
David,
I've
I don't
never,
know what. Yeah.
I have no insights into the markers. If I've seen them, I haven't appreciated them. So,
Okay. All right. The moving marker as the sign of dehiscence there. This one, it's more this the story that's always interesting in these patients. Like this, I can't remember. I think 27 is how old this patient was at the time. And you can see a left-sided aortic arch, but you also notice an indentation on the right side of the trachea as well, and a fullness here in the right paratracheal space. On the lateral view, it just looks like, I don't know, you can almost hallucinate. There's like a second opacity. This looks like arch, and then it looks like that. And there's very subtle indentation on the posterior wall of the trachea here. So it looks like some sort of vascular ring. And with both the right sided and the left sided, you suspect it's a double aortic arch. She's had lifelong history of swallowing difficulties, difficulty breathing, and you can see the posterior compression on the, well, really both anterior and posterior compression that doesn't relieve at any point in time. So it certainly looks like a vascular ring. And then she did go undergo CT here, and sure enough, this is a double aortic arch. It's kind of unusual in the sense that both of them are pretty symmetric. It's not a really asymmetric, like right much larger than left, as we often see. And if you map it up, you can kind of see it's a pretty symmetric arch here. I can show coronal too. The right is higher than the left, as we typically see in these cases. But this is a patient who was symptomatic and did undergo repair here. And that's one of the reasons I wanted to show it, that they were able to, well, they just ligated the left-sided arch. They didn't really have to do anything besides that. But you can see they ligated it between the, uh, or posterior to the left subclavian artery and right there. And they they also ligated her ductus or ligamentum arteriosum, but that wasn't really contributing to the vascular ring in this case. But her symptoms did improve. You can see there, I think there's always going to be a little bit of deformity of the trachea there, but her symptoms did improve with treatment of this. We've done a few of these here, both aberrant subclavians with vascular rings from left ligamentums and probably a couple of double aortic arches in adults like this one. And I don't know, I mean, we have a huge aortic population here. I'm not used to seeing these. I don't know if, I'm guessing you guys probably do them at Wisconsin and Washington and elsewhere. We just don't see it that often.
No, I mean, it's a rare anomaly.
Yeah,
It's like one in
especially
10,000, which is too high.
right, right. That's just what presents.
Right, exactly.
Speaking of another rare anomaly, and this one was just referred to our ILD conference. You know, it's, I don't know if I would just say that the lungs look a little bit busy on this radiograph. What do you guys think? I'm trying to zoom in as,
Yeah, I mean, it's hard to tell on
yeah.
a webinar, but I'm underwhelmed.
Yeah, okay, that's fair. I mean, and that's, she had COVID. She ended up having a neck CT for some reason that showed this. Uh, Lady in her 60s undergoes a series, as you can see, of 4 chest CTs, eventually ends up in a surgical lung biopsy because nobody knows what this is. These are all done outside, obviously, because they didn't send them to us. I think this is, looks like some sort of little duplication cyst. That's fluid, but these things, we rarely get path on these because I think at least when we show them on here, we know what they are. Most of them are very, low in attenuation, ground glass, not solid. Some of them have that little, almost a little Cheerio look to them, or micro Cheerios. Yeah, these were followed over just the course of a few months before they did a surgical lung biopsy, and she didn't. That's a good Cheerio right there in the left lower lobe, and right there as well. I mean, it's pretty extensive here. That one's a little bit more discrete Cheerio, but these were all meningothelial-like nodules. So just the pathologist called it diffuse meningotheliomatosis. Oftentimes, like I said before, and like you guys have shown cases that we don't get path proof because we know what it is and just tell them not to biopsy it. Um, but this is one of the more extensive ones I've seen. Uh, and I don't know if you guys have any other comments. I mean, it's pretty typical other than being
Yeah,
very extensive.
yeah. I think it's unfortunate when these people get biopsied these
Yeah,
days. I mean, I think we live in an era, if you're contemplating a surgical lung biopsy, they should be sent to a tertiary center first before you subject them to a
yeah.
invasive and costly procedure.
And yeah, and right, risky. Yeah. The one thing I was going to say with this case is, it was interesting. The pulmonologist made a note in her, she made a comment in her note about how there's some association with malignancy in the literature of these. And much like the comment you made, Jeff, about the incidence of double aortic arch being quoted as 1 in 10,000, but probably much lower, I would venture to guess these have no association with malignancy. It's just that they're often only described or discovered when somebody undergoes a staging CT, so that there's a base rate neglect issue there. Wouldn't you think so? I mean, because
Yeah,
that's like the typical patient population. They're incidentally discovered often during times of staging for, because they're usually in females, so breast cancer, lung
hmm,
cancer, something else. But I think it probably inflates the number of patients with that have cancer and also have these. That would be my guess.
I would agree. That's the most impressive case I've seen, though.
I thought you or David have shown one that was as extensive.
Maybe,
I mean,
well,
it's
yeah,
yeah,
I've seen some of this. I mean, yours. I mean, they're so pronounced you can even see the little umbilications,
yeah.
on a laptop.
This one is interesting because I have some intra-op photos to go with it. So this patient has this part solid, part ground glass thing in the right lower lobe, medial basal segment. And I'll show this, this is the old study here that I'm scrolling through right now. So this is a course of a couple years. So it's getting bigger, certainly looks like and behaves like it's a small little adenocarcinoma, which is what it turned out to be. And I hadn't seen this one, and the surgeon, I was in the reading room and fielded the call when the surgeon called from the operating room because her question was, because this is so deep, she was going to have to like basically do an extended basilar segmentectomy. But her question was, what the heck is going on right here? Because she sees this funny little vessel arising from the mediastinum right there, and closer to the soup seg, and also involving or adjacent to the pulmonary vein. And this is kind of interesting because it wasn't commented on any of these studies. And if you look at the original contrast study from the outside hospital, it's a little thicker image. But this little vessel feeding this thing, I thought I could trace to an intercostal artery, like right here, clearly coming off of the aorta, off the descending thoracic aorta. And I looked down, I didn't see anything arising from an inferior phrenic or the celiac or anything in the abdomen. But so it looks like it's got a systemic feeder. And then when you really look at it more, you know, it's hard to really trace an airway to this area. And it's got a little bit of some weird partial fissure there, but there's no airways in that area. And so she ended up seeing this in the operating room, and it was a little sequestration that she took out as well. And I'll show you a couple of the images from the intra-op. And so this is that basilar segment, the basilar pulmonary vein to the four basilar segments, and then this is the sequestration tissue that she has in the loop forceps here, and then that's that little vessel. So it looks a little bit bigger actually on this, and it looked a little bit bigger on the non-con study than it had on that original contrast enhanced study from a couple years ago. I mean, that's not a tiny little vessel there, but it was fairly mobile here, and this was a reasonably complete fissure, so she was able to take that out. And on path, they thought it was a sequestration. So just a little bit of an unusual location. It is
Yeah, that
medial, but
is.
yeah.
Hmm.
So
Sequestrations don't have a fissure that defines them. So I think this is an attempted, you know, and it doesn't seem to have an airway, does it? Did they find an airway in it? I'll bet you they didn't.
no, I actually think they didn't comment on it, David. I actually think this may be an airway right here that's just got a little bit of chronic mucoid impaction or something leading to a little higher attenuation, because I think that's
Yeah.
it's calcified there, but it doesn't go anywhere proximally.
Hmm.
So what do you think that is? A little accessory segment or
Well,
something?
I think it's an accessory. I think it's an attempt at making a lung down there. The way sequestration is, but it's got a fissure, so I think it's an extra little
Huh.
lung tucked in. So it's an accessory
Okay.
lung, accessory lobe or something.
Yeah. I mean, it was called a sequestration. I think that was, I don't know if the pathologist called that or if the surgeon just called it that when she took it out and labeled it that way.
I wonder if she could see the fissure if this was a separate little thing that was sort of sticking out. You
Yeah,
know,
this thing, it's this little tongue of tissue that she's
yeah,
grasping in the looped forceps here.
yeah. So I think it's an attempt to make another lung down
Hmm.
there, and it didn't quite work. But the fact that it's separated from the lung by a fissure from the normal lobe, that takes it out of being an intralobar sequestration. And maybe we want to call it extralobar. Um, what was the venous
Huh, that's,
drainage?
it looked like it was, I thought that this was probably a little vein going to the right inferior pulmonary vein right there.
Well,
Yeah, I don't
that would,
know, like,
yeah,
yeah.
yeah, I agree. So
So,
an
yeah,
extra lobar should drain systemically, but maybe this is a sort of a hybrid. So if we're going to call it sequestration, I think it fits better with extra lobar, since it has its
huh.
own pleura surrounding it.
I guess I've never really thought about the lack of fissure for an intralobar sequestration, but huh,
But there is not a fissure.
yeah, interesting. Okay, good.
Okay, so
I'll
let's
have to go
call it
back and look at some of them.
let's call it it's got some features of extra lobar sequestration in terms of having its own pleural envelope.
Yeah,
That's part of the definition. Um, and then the venous drainage, is supposed to be systemic, but you know, this one's being aerated, so it must have some connection with lung tissue to keep it aerated if it
right.
doesn't have a good bronchus. So I think it's kind of a hybrid, intralobar, extralobar.
Yeah. So,
I really
okay. Well,
think I
that's good.
like this.
Yeah.
I think this is a great case, but it's unique in my experience at least.
And I think as much as anything else, it's just like important to recognize when things look funny because it
Yeah,
certainly threw the surgeon for a loop what it was. So, and she just wanted to make sure she wasn't ligating the wrong vessel,
got
and
it.
resulting in infarct of lung that she wasn't going to take out.
Hmm.
So that is a good distinction. I'll have to look back at at any of the ones that I've seen, the like sequestrations I've seen.
Ask
Yeah, I've
the
never seen one with a fissure.
right. Ask the pathologist to see if they could find any bronchi in there. That would
Yeah,
be cool.
I will. Okay. I'm going to show, so I've got two cases of Al Kappa in adults, and neither of these are new, and I've shown a couple before. I think the question today came up with physiology and direction of blood flow in pulmonary arteries. Now, this is an adult, and this patient did undergo reimplantation. And you can already see when you look at the pulmonary artery on this coronary CT that there's a blush of contrast in sitting in the middle of the pulmonary artery. And that, in fact, does come from the left coronary artery, which is huge. This is a patient who had had chest pain, underwent a stress test that was abnormal. I can't remember what else it, eventually led to a cath and coronary CT. But, typical findings of a fistula, which is what this essentially is you've got blood that's flowing down a pressure gradient. So you've got systemic pressure here, and you've got pulmonary artery pressure here. And so over time, that increases flow, and you end up with seal phenomenon, and the blood flowing backwards from the left coronary back into the pulmonary artery, as you can see with the direction of the contrast in that jet of opacified blood. And so, no surprise, this patient has a lot of collaterals and macroscopic collaterals that you'll see some of the septal perforators and things communicating with that left side. And this is occasionally we see this in adults. I think this is the second or the third one I've seen. She also had AFib, and this was a little bit of combination of slow flow, but also some thrombus adherent to the left atrial appendage. So that's one that's more like typical. Yeah, why that patient doesn't present as a child, I'm not sure. This is an interesting one, though. This is one that the patient presented as an adult. Similar story, ended up with a stress test, had some worsening symptoms, ended up with a cath. And on the cath, which I'll show I'll show the cath right now. the cath, they were unable to find the left coronary artery. So this is the right coronary artery injection, and you can see filling PDA, and they're going to swoop around here. And posteral, it looks like that's probably posterolateral branch, and then some wraparound into the LAD. And then this is the LAD that just kind of essentially blindly ends right here. And you can see a little bit of filling of the circ right there. And this one I can believe more why the patient didn't present until adulthood, in the sense that you can see the left coronary artery. It's not as big because you don't actually have a huge fistula here. And that's because at surgery, when they found this ostium of the left main coronary artery on the pulmonary artery was less than a millimeter. Like they couldn't even, they could see it, but they couldn't really cannulate it with a probe. So in this case, they ligated this and then did a bypass to the left-sided system. But this is another case of Al Kappa with almost an atretic left coronary artery, and really just this patient had developed sufficient flow through their right coronary system to supply the entirety of their heart from, until adulthood. But that's, this one I can believe why they didn't present in childhood, because this stenosis kind of prevents the big fistula and the steal phenomenon. The other one, I'm surprised they didn't present earlier in life. Um, yeah, so those are just two cases of Al Kappa with slightly different presentations. I think we can explain the physiologic reason why. So I don't know if you guys have
Very
any
cool.
comments on that. Oh, I will show, this is kind
No.
of, I just think this is kind of funny. This was whoever decided to send this for FFR. I mean, it's it's like, okay, yeah, it may be functionally significant. I just, this is unfortunately just a waste of money for the patient or for the
Oh my
hospital or for
gosh.
both. Yeah.
The whole thing's
But
made up.
okay, Jeff, that's what I have, so I'll stop there.
Awesome. Thanks. All right, David, do you have any cases?
I have one.
All right, I'm gonna give you control.
You see radiograph?
We do.
So this person has a mediastinal mass. This is a woman, I think in her 50s or 60s, does have this mediastinal mass bulging on the left, but also on the right. And on CT, no surprises. She has an anterior mediastinal mass that looks fairly uniform. Um, Fairly soft. I think I would put thymoma as first consideration here, ahead of germ cell tumor, and doesn't continue into the neck and stuff like that. And this was biopsied. We're awaiting the pathology on the resected specimen, which was just handled last week. And this is a thymic carcinoid. And I can't remember the last time I saw a thymic carcinoid tumor, so I think they must be fairly uncommon. What's your experience? Carcinoid
I've
tumors in the
seen
thymus.
I've seen three.
Hmm.
They're indistinguishable from other thymic neoplasms, but unlike pulmonary carcinoids, they tend to be more aggressive.
Hmm. I think on the basis of the needle biopsy done at the outside hospital that was reviewed here, there were some mitoses, in this thing. So it probably is going to be at the aggressive end of carcinoid
Yeah.
tumor. But we're waiting for the final result. And this person got a gallium dotatate PET scan, and this lesion did light up as expected for a neuroendocrine tumor. So, in my experience, fairly rare thymic tumor, thymic carcinoid. Travis, have you seen a few of these?
I've seen at least one, and I have no idea if I've seen more than one. And I remember was big like this and had some calcium in it, but yeah, I mean,
Yeah.
certainly
So there,
less than five,
yeah, I
probably
think
less than
that
three.
on one of the non-contrast images that I seen on a different scan, there was a little bit of a little hint of calcification, just fairly faint, but there was a little bit of whiteness in there on a non-contrast scan. This is contrasted, and I don't actually see the contrast in there or the whiteness in there now. Okay, so that's all I have this week.
Cool. All right. Okay, so you see my screen okay? So this
Yeah.
first case, okay, this first case is a patient who has this mass, little cavitation, and all these tiny nodules. Can't hold their breath because they're quite short of breath, but you can see all these tiny nodules. Most are in the upper lobes. And then on the soft tissue windows, you'll see that this mass seems to extend towards the posterior, the paraspinal region, and there's this sort of low attenuation material tracking into this, even into the, I think this is longus coli here, but tracking into the paraspinal musculature along there. And then you'll see as well, there's osteolysis of several vertebral bodies here, fragmentation. I'll show a sagittal on the T-spine reconstruction. There you can see a nice, you see this bone, this one's collapsed a little bit, and then you got these multiple levels of osteolysis, but you'll notice the disc space is relatively preserved, which is pretty typical for this entity. So putting it all together, this is just a really nice example of disseminated tuberculosis with Pott's disease. So this TB involvement tends to spare the disc spaces. It's often multi-level, and having the lung findings here is quite helpful uh, to suggest this is tuberculosis. So this is sputum positive TB with bad spine involvement. This next case is cool. My colleague Mark made a great diagnosis. So this patient, this was to look for a pulmonary embolism with short of breath, and it just had surgery. And it's always good to know what kind of surgery people had. And you can see on the study, there's this upper lobe ground glass opacity. It's fairly extensive. Kind of looks organizing pneumonia-ish. It's got discrete areas. Nice, crosses the fissure fine. So great look for acute lung injury, organizing pneumonia pattern. And uh, he saw this radiograph. So this lady had been sent here for a complex repair of this. You can see this tibia and fibula. The tibia in particular doesn't look quite good. So he had suggested fat embolism syndrome, which of course is a really clinical diagnosis. And usually they have altered mental status. And sure enough, she presented with, shortly after this CT, she had some altered mental status because they did a bunch of neuro workup. So um, the working clinical diagnosis is a fat embolism syndrome. It's just unusual that she's older, but all the cases that I've seen have always been after instrumentation and not de novo trauma. Usually it's younger males, long bone fractures, pelvic fractures, but I mean, in all the years of doing trauma imaging, I've just not seen a case present without the orthopedic surgeons doing their work. So, nice case of fat embolism syndrome. I haven't seen one in a long time, and I was wondering if they had changed something in their practice, but maybe we just don't get it that often.
Jeff, some people get short of breath after spine surgery, these elaborate spine fusions where they go and put pedicle screws in at multiple levels and stuff
Uh-huh.
like that. I've seen a number of people whose chest radiographs get cloudy a day or so after that. They're short of breath, they're symptomatic, they're febrile, and I think that's fat embolism
Oh, that's
syndrome. And I think those pedicle screws are very good at sort of mobilizing the fat, like little propellers and speeding into the bloodstream.
right.
So I've seen
'Cause
it with extensive spine surgery, which people don't think of with this syndrome. It's not just lung bone trauma.
Yeah. Yeah, like I said, the ones I've seen have all been immediately post-surgical, not during the actual initial injury.
I
And I
I also
suspect it's because it's not just the breaking of the bone, but rather the sort of the probably pressure changes of drilling in all this hardware and disrupting the marrow.
right, and I also think that I found that the surgeons they don't cotton to the suggestion that it's fat embolism. They will just reject that immediately. So they're not very sympathetic. And thank God it usually gets better.
Yeah, that's the thing is it's supportive care.
Right.
So, but yeah, the altered mental status is important because, of course, differentials a stroke.
Hmm.
All right, this was just kind of a cute finding that I have not seen. Seth mentioned that he'd seen this before, but I don't think Travis had. So I can't remember why this was done. It was just a routine chest. But I saw this vessel right here that looked like a superior pulmonary vein, but it was kind of in a weird position, almost looked like a top vein. You can see it comes in and inserts on the top portion right here of this like sort of common antrum of the left pulmonary veins. But there's a separate standard superior pulmonary vein. So it's like a duplicated one, and you can follow it all the way out, and it does come all the way up here. Just it's like an extra vein. And we've seen plenty of top veins on the right. Howard's shown several in this conference. I think one that was missed by the people doing ablations, and the AFib persisted. But I don't know. I've never seen anything like this. Have you, David?
No.
I'll make a.
Jeff, what does
It's
the
really
airway
cute.
branching pattern look like?
It was normal, which, yeah, I looked for other congenital things and couldn't find any. But here it is right here. You can follow it there, and it just loops up right there. So a top left pulmonary vein. I looked for it online. I couldn't find anything, but it's like an accessory vein. But there's no deficiency in the primary vein, so I guess it's just like a supernumerary vein. But I thought it was just kind of a cute finding. Or at least I haven't noticed it before. This is a cool case. So the imaging itself isn't interesting, but the pathology is quite. Unfortunately, I don't have the pathology. We won't get it because there's already a diagnosis. But this lady has a bunch of lung nodules, and they look like Mets, right? They're just some solid ones, just hanging out everywhere. And what's interesting is if you look in her abdomen, she's got this large cystic thing, but then she's got all this soft tissue here. So, I mean, this looks ugly. You'd think some kind of sarcoma or something, or metastatic something. But her history is she had a hysterectomy for a fibroid uterus. And so had that a long time ago. You can see it was an old midline vertical incision, not like a laparoscopic one or transvaginal, which they do a lot more now. And then digging back, at some point, one of these big guys got biopsied and it's just leiomyoma. So this is a case of benign, well, I don't know if it's benign, but so-called benign metastasizing leiomyoma or leiomyomatosis with lung involvement. And this one, I suspect it gets in the vasculature and works its way into the chest. You can see here there's trying to get towards the, looks like, I don't know, this large cystic component, but that's what I would suspect. It works its way into the IVC and then metastasizes to the lung. But I've only seen this a couple times, and there's nothing, again, nothing exciting about the lung imaging, but sometimes that old history, and I was looking in the literature, and almost every case is reported after surgery, not before. So it may be that during the hysterectomy or myectomy or whatever, that these cells get dislodged. And they can treat the patient with letrozole, and that can actually make them get smaller as well. So you can treat them hormonally. But they can get quite large. I think I remember seeing a case in residency that was quite impressive.
So, Jeff, how do you think this,
Yeah,
what was the route for the establishment of this big mass? What compartment is this in? Is this adjacent to the
uh,
bulging up from where the uterus was before, or I guess it was?
well, it looks like it's. I mean, it's intraperi. I mean, here it looks intraperitoneal,
Yeah.
because it's anterior to. There's the. It's anterior to the iliacs there, and I mean, there's some of it back here deep in the pelvis. But I presume it just worked its way up the abdomen, and it's just, and then this big cystic component, which I guess it went under cystic degeneration, which fibroids do or leiomyomas do, and it's gotten so big now, as you can see, there's the properitoneal fat, so it's just hanging out in that uh, um, upper peritoneum. I don't know, and it looks like it's rotated the kidney about 90 degrees, and it's pushing up the retroperitoneum. Let's see if we can do a coronal here.
You don't think it's retroperitoneal alongside the kidney there? I
Well,
think it
that
is.
part may be, yeah. I wonder if that is because it is pushing it up, but I think this is intraperitoneal here, but I may be wrong. So this, right here, it looks like it's in continuity with this mesentery here.
Hmm.
But yeah, I think, yeah, where it's, and see, it's separate from the colon here, which that part would be, I don't know what that it's separating that out, but there's a tissue plane here. But these can invade the IVC or the azygous system as well
Hmm.
and metastasize to the lung. So yeah, they just treat it with usually like hormonal therapy, and you could debulk any abdominal lesions that were causing problems, but kind of just a cute case of a diagnosis I haven't seen in over a decade outside of this conference. All right, well, that is what I have this week. Well, I will talk to you all next week, whoever's
All right.
around.
Thanks.
Thanks,
Thanks.
everyone.
Bye.
Bye bye.